cases also. Today our speaker is Dr. Diluk Pinto. He's a consultant surgeon as well as endocrine surgeon, and he's a senior lecturer in surgery, Department of Surgery, Faculty of Medicine, Ragama. You know that the Ragama Medical Faculty is a reputed place for endocrine surgery. That after retirement of Professor Ranil Fernando, Dr. Diluk Pinto replaced his position. Thank you very much for giving us the opportunity to for your presentation, Dr. Diluk Pinto.
Thank you, Dr. Dixon. I think you all should know that Dr. Dixon was my senior some time ago. So I'm very grateful for this grand opportunity where I can share some of the details which we teach at our Faculty of Medicine, University of California, with you all. Who's our host today? Dr. Gayan, is it you?
So you can share.
Okay, right. No worries. Today we don't have any slides to share as such, but I would feel, I mean, if somebody is answering a couple of simple questions, I mean, this would be much more interactive.
Yeah, you can go ahead. No problem.
Yeah.
Yeah. Okay.
Okay, right. So the main topic today would be on how to do a short case when it comes to the thyroid gland properly, right? So just to sum up the things, I mean, we as examiners, we look for how you take consent from the patient, how you give adequate privacy to the patient, how you expose the necessary area, then how you position the patient, and whether you are going to need a chaperone or not, and whether you are giving adequate lighting to this scenario. So about 5 or 6 things when it comes to any short case that you have to think about before going into on examining the patient. Can anybody tell me, I mean, anybody can answer, right? I mean, there are no correct or wrong answers. Can anybody tell me how you are going to take consent for a short case where there is a big goiter here? It's a very short, in short, if anybody can tell me, that's fine. Come on, guys. I don't want to name names and ask. Come on, I mean, otherwise it would be really a one-sided lecture sort of thing.
First introduction, sir.
No, I'm asking for what's your name?
Dimitri.
Dimitri. So I just want to know, say I am the patient. Now you are here. Now 2 examiners are beside you, and I'm just asking, you take the consent to examine the neck.
Can I examine your neck?
Yeah. So now you can't do like that, right? So you have to say, what's your name again?
Dimitri.
Dimitri. So you have to say, now we don't know anybody else, right? So I am Dr. Dimitri. What is your name? So I say I'm Pinto. So Pinto, can I examine your neck today? Right? So that's sort of like 10-second, 12-second proper introduction should be there, definitely. Right? So you say your name as Dr. Dimitri and you ask who the person is in front of you. And is it okay if I examine your neck today? Then one of the main things you have to then next say is whether you have pain or not. Because in any of the short cases, we are not expecting you to elicit pain. Make a වේදනාව දනවන්න අවශ්‍ය වෙලාවක් නෙමෙයි. But in real life, of course, if you think about acute cholecystitis, acute appendicitis, you have to elicit pain, right? In peritonism, in features like guarding rigidity, so there's going to be considerable amount of pain. But in the short case or the long case, we are not expecting you to elicit pain. So because of that, you should definitely ask beforehand after you introduce the both parties, you have to definitely ask whether you have any pain here or not, right? We don't know. I mean, if it is painful and then you start pressing and patient is howling in pain, then probably you might get a low mark because you have given a bad hard time for the patient. And always remember, there's going to be candidates before you and candidates after you. So if you elicit pain and the patient is uncomfortable, so we may not be able to proceed with the examination. Okay, right. Can anybody tell me how to get adequate exposure for a neck lump examination? What is the adequate exposure? Now look at me. I think most of all of you can see me. So I'm wearing a t-shirt where my neck is open. Some of my manubrium is in view, right? So what do you think? Is this enough for a goiter examination? Anyone can answer.
No, sir. We have to expose your entire neck and also be able to visualize the clavicles at least.
Okay, right. Something like this coming. Okay. How about this?
No, sir. A bit more below, sir, because we'll also have to do the percussion for retrosternal extension. So
Okay,
it should.
right. No, so Dr. Hamid is discussing that it's ideal that you go a little bit below when it comes to exposure because you might have to go for retrosternal extension. Okay, I agree with that as well as I disagree with that, but we will be discussing about retrosternal extension later, so we will come to that at that point. But for the time being, imagine this sort of exposure is adequate. I specifically wore this instead of a shirt and a tie to demonstrate this is adequate exposure to examine the goiter, right? Okay, what about the lighting? Yeah, anybody can answer. Lighting. So I will answer. That's a very simple question. I mean, to examine the neck, you don't have much lighting because it's already out in the open. But whereas if you are going to examine somebody's groin while the patient is standing, probably you may need your torch on, or maybe you need some light on top, or maybe you have to open the curtains a bit so that daylight would come in. Can anybody tell what is the position for the patient to be when you are examining the neck? Is it seated like this, or is it supine on a bed?
The patient should
Sitting
be
position, seated on a chair.
Yeah. So most of in any part of the world, usually thyroid examination, when they are presenting with a goiter, they will usually be on a chair, right? So that is adequate because there should be space for you to go behind and examine, right? So sometimes the patient may be sort of in a chair, and the chair is near a wall. So maybe at the starting of the examination, you may ask the patient, excuse me, can you stand up a little bit and go forward? And then maybe take the chair to the front a bit so that you have a gap in between the patient's chair and the wall, so that you can go behind the patient in 180 degrees and then start examining. All right. Okay. So do we need a chaperone for this? Say this, most of these patients should be women.
Yes, sir.
So usually, as this is done very out in the open and you are not going towards breast region, you may pass without having a chaperone, right? So, but in all the other instances where you are going to do breast examination, abdominal examination, groin or genitalia examination, I think definitely you need a chaperone if you are going to look examine a patient who is not of your sex. Remember this, right? Not of your sex. I mean, not necessarily be a woman or a man. So most of the times the two examiners act like chaperones. So most of the times your problems are solved. But if there is two male examiners, the candidate is also male and the patient is female, there is always the running nurse hanging around. So you can ask her to accompany you as the chaperone. Okay. So now, as Dimitri said, now we go to the patient. Okay, I'm Dr. Dimitri. What is your name? My name is Diluk. So I say, okay, Dr. Diluk, can I examine your neck? Yes. Do you have any pain? No, I don't have any pain. මට කැක්කුම දිනවද? නෑ මට කැක්කුමක් නෑ ડોක්ටර් ප්‍රශ්නයක් නෑ. Okay, no need of a chaperone. Lighting is good. Patient is comfortably seated on the chair and adequate exposure as Hamid said. Now we are going to go forward. So this preparation should be around 10 to 12 seconds, maybe 15 seconds tops, right? Okay. So now what you have to understand is the current short case examination is you have two bays, BAY, two bays, where in one you will have the head and neck, lumps, bumps, that sort of thing. Sometimes breast also, and on the other one you have abdomen, inguinal region, ulcers, orthopedics, vascular, that sort of thing. So two bays, two areas. So in each one of these bays, you are going to face two short cases, the minimum, right? So 10 minutes for each bay. So 5 minutes for one short case in each bay, right? So you will be having two examiners going with you along for this 10-minute one bay, right? So basically you have 5 minutes for each short case, but you cannot examine throughout the 5 minutes, and at the end when the bell rings you can't say, okay, right, this is like this, right? So remember, at least you have to limit yourself for the examination for about 3 minutes. Examine karagana ihla meka karanna bෑ. You have to that's why you have to train yourselves to do the necessary examination in about 3 minutes, and then maybe present your findings, important findings, in about 30 seconds with a diagnosis and a plan probably, and then face the music. That is, answer some questions from your examiners. So at least 1.5 minutes for discussion, right? So that is roughly what we expect from you. So even though you go down in one short case, you try to do the next short case better, right? So that it balances out some of the deficiencies you may have in one short case. All right. So what are your thoughts on running commentary? I would like somebody to speak up other than Dimitri and Hamid. What is your comment on running commentary?
So it's helping time saving so that we can have more time for our discussion.
Okay,
rather
yeah,
than
Dr. Abhiratna, now it's like this, right? Sometimes it helps, sometimes it may be counterproductive. We can make ඔයාට හෙනයක් වෙන්න පුළුවන් because see now ඔයා හිතන්නකෝ, you think about you all must have seen cricket commentary. So now then the fellow starts saying, okay, නේ පන්දු යවන්න මේ අන්තයෙන් පටන් ගන්නවා, ඕන පන්දුව පිරිමදිනවා, ඕ දැන් ඕ දුවගෙන එනවා, මේ අවස්ථාවේ වේගෙන් පන්දු එල්ල කරනවා, වේගවත් so something like that. So what I mean, that is not what we should understand by running commentary, right? So running commentary is like that. Say you have a lump here. Say now it's a ganglion probably, right? So you have a lump here, and then you say now you are doing checking for skin attachment, right? Skin attachment. Then say you don't see skin attachment. Then you say there is no skin attachment. එහෙම නැතුව කියන් යන්න හොඳ නැහැ. ඕකේ මම දැන් මේ ස්කින් ඇටැච්මන්ට් බලන්න තමයි යන්නේ. ඔන්න මම බලනවා. මේ පැත්තට අදිනවා, මේ පැත්තට අදිනවා, මෙහාට අදිනවා, මෙහාට අදිනවා. නෑ වගේ. That is not running commentary, right? So running, if you start saying like that, then it is very, very, very difficult. But you check it, you say, okay, skin attachment is there or not. Then you check for cross fluctuation, say it is there or not. So that would be adequate if you are going towards running commentary. Or else, I mean, nobody would be cross with you. ඒ කියන්නේ ඔයගොල්ලෝ කවුරු තරහ වෙන ලකුණු අඩු කරන්නේ නැහැ. ඔයා examination skills හරියට කරන් ගිහිල්ලා at the end you say, okay, this is a ganglion. Then we might ask why you say so. Then you say cross fluctuant, the placement is correct, no skin attachment, brilliantly transilluminant, right? එහෙම කියන් ගියොත් අපිට ප්‍රශ්නයක් නැහැ. But the problem is now you waste a lot of time by giving a running commentary, as well as then at the end you turn to the patient and tell the examiner and tell the same things over and over again. I examine this patient who is comfortably sitting on a chair and now එහෙම කියලා. එතකොට ආයි මුල සිට සරලව most of you are trying to say that eats into your discussion time. ඒක ඔයාගේ discussion time එකෙන් ගොඩක් වෙලාව අඩු කරනවා. So you either go with running commentary or you keep your mouth shut, do what's necessary. Remember, the most important thing is doing what is necessary, right? මොකද මේකේ ඔයාගේ we are not giving any marks for your language proficiency. ඔයාගේ මේ ඉංග්‍රීසි භාෂාව ඉතා දක්ෂයෙක් වෙනවා කියන එක ලකුණක් මෙතන නැහැ. Right? මෙතන ලකුණු දෙන්නේ the only way we give marks is what you do and what you demonstrate. ඒ කියන්නේ examination skills හරියට කරනවාද? ඒ කරපු දෙයින් you understand what's happened and then you say the correct thing. And there is osteoma here and you try to check the consistency and it is rock hard, and then you start doing skin attachment, it is not attached. Okay, then you start cross fluctuating. So now when there we get pissed, right? Because it's like you are trying to see whether a rock is fluctuant, and maybe worse, you may go ahead and do trans-elimination on this rock hard lump as well, right? So that's something which really pisses off the examiners, because you are actually not understanding what you are doing, right? So in that sense, I would suggest you, if you are good with running commentary, okay, but limit it to what you actually do and the result. Rather than going on and on and on, just talking and talking, then examiner also gets bored. We are not sure whether you are only telling it or actually doing it, because our main concern is looking at what you do, right? Okay, right. In any short case, there are main areas to check, right? So now I'm going to mention, if you like, you can write this down also. For me, about 5 or 6 areas to check in a goiter. So first one is you have to establish that it is a goiter or not. Goiter or not. Secondly, if it is a goiter, what is the shape of it? Thirdly, cervical lymphadenopathy. Fourthly, tracheal position. Then retrosternal extension or not. Lastly, thyroid status. So if you want to take a good mark on examination of a goiter, you should briefly touch upon all these 6 areas. Say if you miss 1 or 2 areas, that's going to make you lose a lot of marks, right? Because your examination is incomplete. So you have to know, right? So this is an organ, it's an endocrine organ which produces hormones as well. So if you miss the thyroid status part, then actually there is absolutely no point in examining this at all, because you don't know whether it is producing high amount of hormones or low amount of hormones. This may not be the case when it comes to a breast lump, right? Okay, so can anybody tell me how to say that there's a lump here? So all of you will be talking about an anterior neck lump, right? So whether this anterior neck lump is a goiter or not, how to say that? How to do that? Anybody can say.
It moves up on deglutition but doesn't move up on protrusion of the tongue.
Yeah. So Hamid, that is wrong, right? That is wrong because your thyroid starts at the cecum, foramen cecum of the base of the tongue, the very end of the tongue, so that ideally any lesion or having any connection to the tongue base should come out when you protrude the tongue, like that, right? So I think don't stop yourself at that, but what you should say is, if something is going up and down when you are swallowing, probably it is a goiter. That's enough. No need to think about the tongue because that's a completely different thing where you talk about the short case thyroglossal cyst, which is bit rare and bit away from today's discussion, right? So thyroglossal cyst will not move up and down with deglutition, but only go up when you open your jaw halfway, stabilize it with your hand, and then ask the person to put the tongue out. Like, okay, open mouth halfway, stabilize, put the tongue out while holding that lump. So you should be able to feel the lump going up. It's a tug, right? Okay, so that is not going to happen in most of the goiters, right? I agree with you to a certain extent because this thyroglossal tract is almost non-existent later on. But we don't talk about this tongue, pulling out the tongue, I mean, putting out the tongue, right? So we only talk about that the goiter is going up and down. Okay, Hamid, can yourself tell me why does it go up and down? Because we may ask this at the exam.
Because it's attached to the pretracheal fascia.
What
So
do you
on
call that?
swallowing,
The ligament? Berries ligament, RJ, yes. So the thyroid gland is attached via the Berries ligament to the trachea as well as larynx, right? So you have to always remember it is the larynx with the thyroid notch which goes up and down, right? Up and down with swallowing, right? It is not the trachea because trachea is attached to the larynx, it goes up and down. Agreed? So then the thyroid gland is attached by Berries ligament to the pretracheal fascia to the trachea as well as the larynx. So if larynx goes up and down, thyroid goes up and down. All right. Okay. So there are other lumps also which may go up and down, like if you consider a lymph node which is attached to trachea or the larynx, tuberculous lymph node mass, that also may go up and down with swallowing, but it is very rare. I don't think it would appear in your exam, but if somebody asks you that question, you can answer as such. All right. Okay, so Hamid, how do you think that you establish this swallowing and going up and down? What do you have to do?
we have to tell the patient to keep some water in their mouth and then look up and then give them the instruction to swallow.
Yeah. So don't make this very, very difficult procedure, right? ගොඩක් අය ඒක කියනවා අම්මෝ මෙන්න වතුර විදුරුව ගන්න වතුර උගුර බොන්න ඒක කටේ තියාගන්න බොන්න එපා. ඔන්න මං කියද්දි බොන්න. ඉතින් එච්චර දුරට කරන්න අවස්ථාවක් නැහැ. I mean you don't have to go to that. I mean you give the water and ask them to take a sip while you get down to that patient's level because the patient is sitting, you are standing, right? As you know that from our days of checking measurements in a pipe, minum sarave මේ බලනවනේ අපි උඩ ඉඳන් බලන්නෙත් නැහැ යට ඉඳන් බලන්නෙත් නැහැ නේ අපි බලන්නේ ඒ level එකේ ඉඳන්. So as such you have to get down to that patient's neck level and then have a look whether it is going up and down, right? Okay, right. So now we established that. Okay, the second point is what's the shape of this goiter? It is very important. Can anybody tell me what are the shapes of the goiters which you come across? Hadadala goiter.
Butterfly shape.
Yeah, that is the normal shape of a thyroid gland, right? අපි දැන් pathologies නේ බලන්නේ මොනවාද තියෙන වර්ග හැඩතල වර්ග.
Solitary.
Yes, then see Dilki. Now it's important. Now you all understand. See the way Dilki answers. She answers as she's asking a question. Solitary, and then she answers in single words. Dilki, this is nothing against you, but you can change this, right? So when you are answering in single words, as if you are asking a question from the examiner, that shows you are not sure of what you are talking about. කියන දේ සම්බන්ධයෙන් confidence මදි කියන අදහසක් එනවා ඒකෙන්. ඒ නිසා වඩා හොඳ උත්සාහ කරන්න give the proper answer and don't let it ring like a question. එක නිකන් ප්‍රශ්නයක් අහනවා. Examiners ලගෙන් ප්‍රශ්න අහන්න තේරුමක් නැහැ. We are asking questions. You are supposed to give us answers. ඉතින් මේක කිව්වනම් ඩිල්කි හොඳයි. Solitary thyroid nodule. Right. So the voice is so solitary thyroid nodule. So everybody knows, okay, you are confident about this. Right. Right. So one shape is solitary thyroid nodule. Anything else, Dilki? Dilki? Anything else?
Gross enlargement, diffusely enlargement of the thyroid gland.
No, I think you want to say is diffuse enlargement, right?
Yes.
Diffuse enlargement. Thyroid granthiyama වම සහ දකුණ both sides diffusely enlarged with the isthmus also, right? Okay. Solitary nodule, diffuse enlargement. Obviously, the other one is
Multinodular goiter.
multinodular goiter, right? Okay. But now you have certain other areas also. Sometimes you may have a goiter as well as a lateral lung. What is this lateral lung? There's a goiter and there's a lateral lung. What do you think this lateral lung is?
Cervical lymphadenopathy.
Correct. So you may be dealing with a person who is having a cancer and metastasis to the lymph node, cervical lymph node. So it's a rare thing, but may happen. Then the other one is you are feeling one nodule, like a big nodule. Then you think it is solitary thyroid nodule. But after a while, when the patient comes with the ultrasound scan of the neck, then you may find that there are small other nodules also. Right. So then we call this a dominant nodule of a multinodular goiter. We call this a dominant nodule of a multinodular goiter. So this diagnosis you may not be able to do to achieve as a clinician. You think it's solitary, but then there are small ones which are only seen by ultrasound. So that is fine. But you have to always remember, if you find only one big nodule, it is either a solitary thyroid nodule or a dominant nodule of a multinodular goiter. So now we have about 4 or 5 shapes of goiters, but basically multinodular goiter, diffuse goiter, and solitary thyroid nodule. So when you, Dilki, so how to examine this? Where should you be when you examine this thyroid gland?
Behind to the patient, sir.
Yeah. So say I am the patient, so you should go behind me, right? And then place your hands like that. Okay? Dilki, shall we check both thyroid lobes together or separately?
No, sir. We stabilize one part and examine other part.
Exactly. So you want to check the right side, so you push from the left side a bit. Then you stabilize, then you check from the right side. And then when you want to check the left side, you press from the right side, stabilize, and then check it. Right, correct, exactly. Why don't we do both sides together, Dilki? Can't we do both sides together?
So I think that carotid, I don't know exactly.
Yes, okay.
If
All
you
right.
compress
So
carotid.
yeah, so Dilki, now it's like this. Even in the exam, certain things you may know, certain things you may not know. If you don't know, it's always best to say, I don't know, right? Even at an exam. So it gives us as the examiners the opportunity to ask something else from you. But sometimes if the question is very basic, we may be a bit upset. But most of the times we may get a chance to ask you something else, right? But you will not get marks for saying I don't know and being honest about it. We only give marks for what you do and what you say. But if you say you don't know, then we have the chance of asking something else, which you may have an answer. Okay. Anybody else can tell me an answer for that? Whether can we examine both sides together? Actually, there are 2 answers for that.
To compare, sir.
අපි දැන් තව කෙනෙක් අහමු දැන් Dimitri, Hamid, Kulini and Dilki were answering. Anybody else? RJ also gave an answer.
So if we do 2 things at once, we can't assess one part.
Okay, who was the, let's allow that boy who spoke. පිරිමිලා කවුද කතා කරපු කෙනා පොඩ්ඩක් කියන්න.
So if we assess the both sides at the same time, we can't have a proper assessment of the lump.
Yeah, because our brain does not analyze sensory inputs from both sides at the same rate, at the same intensity. එතකොට ඔයා දෙපැත්ත බලද්දි ගොඩක් වෙලාවට ඔයාගේ dominant hand එකකින් එන එක තමයි එයා අදහසට ගන්න. අනිත් එක ඔයා මේ වෙලාවේ ගොඩක් anxious වෙලා and you are at a very high level of anxiety, so that you may not understand what you are doing and you may say completely different thing. So don't do that. Just examine one side first, then examine the other side next. It's very easy. Anything else? Any other? I think Dilki touched upon this. I think she couldn't finish that theory. Anything else?
If we compress the carotid arteries both together,
Is it the carotid artery you want to press? Or anything else? Something else? Carotid body, right? So you do that, then it's a carotid massage. Then the patient may go into. What will happen to the heart rate if you massage?
Baroreceptor stimulation.
Yes, so
Heart rate reduce, sir.
heart rate reduce. So the question is, what happens to the heart rate? But I think Sayumi answered baroreceptor stimulation. Yes, that is the physiology. But in these exams, you have to always listen to what our question was. My question was, what happens to the heart rate? So to that question, the answer is, it reduces bradycardia. Then if I ask you, okay, why does that happen? Then Sayumi can answer, okay, that is due to baroreceptor stimulation. Understood? Otherwise, you may give, most of the times you are giving answers to different questions. Probably because you are anxious. But always keep your eyes open and listen to what we ask. Most of the times, what the question we ask is very simple, very damn simple. Okay, right. So what is the importance of knowing these shapes is that you can get an idea of what sort of a disorder, what sort of a thyroid disease you are dealing with, right? Okay. Now somebody can tell me, දැන් ඔය උත්තර දුන්නේ නැති අයගෙන් කෙනෙක් කියන්න උත්සාහ කරන්න. Diffuse goiter still ලෙඩ මොනවාද? What are the instances where you get a diffuse goiter? දෙකක් කියන්න.
Graves disease.
Graves disease, කල්පනී.
Endemic goiter.
නෑ endemic goiter කියන එක කියලා එකක් දැන් නෑනේ. endemic කියන එක ආවෙම iodine deficiency එක නිසානේ.
physiological goiter,
Good. කාට දෙන්නේ? දිවිලි.
young population,
Young
Pregnant baby.
pregnant, yes, in pregnancy you get the physiological goiter, and when you are in and around adolescence, like when you are becoming your menarche, those era, you may get a physiological goiter which goes away, right? So pregnancy, so physiological goiter is one, and in Graves you get a diffuse goiter. What's the other pathological condition?
Hashimoto's thyroiditis.
Correct. Hashimoto's thyroiditis. Most of the time, when time goes on, you may have some nodules occurring even in Hashimoto's. But of course, yes, early Hashimoto's, most of the time you get a diffuse goiter. Harini, then you find no nodules but diffuse enlargement. This is usually either of these one, Graves, Hashimoto's, or maybe physiological. All right. Solitary thyroid nodule දැක්ක ගමන් මොකද හිතෙන්නේ? What are the diseases? Thyroid එකේ තනි ගෙඩියක් දකින්න. ඔන්න වෙලාව යාගෙන එන්නේ කියන්න ඕන.
Thyroid.
Yeah, Monasha.
Pathological, sir.
Monasha. Okay. කියන්න කවුරුයි? Pathologist තමයි අහන්නේ.
follicular adenoma,
Okay.
cyst in the thyroid gland,
Okay, agreed. Cyst
Thyroid.
thyroid cyst,
Thyroid carcinoma.
thyroid cancer,
Lymphoma.
Okay, a bit rare. Okay, so basically now, as I mentioned earlier, either this is a true solitary thyroid nodule. In that scenario, most of the time you have to worry about a thyroid cancer, right? Then to think about a dominant nodule in the multinodular goiter also, right? The සමහර අය thyroid cyst, yes, cyst එකක් වෙන්න පුළුවන්. අපි follicular adenoma කියන එක ඒක හරි, but in a exam scenario අපි සාමාන්‍යයෙන් pathological diagnosis වැඩිම කියන්න යන්නේ නැහැ, right? Because that is ultimately going to go with histology and microscope, involving microscope and all that. එහෙම කියන එක ටිකක් වඩා වරදින්න පුළුවන් කෙනෙක්ට. ඒ කියන්නේ microscopic diagnosis කොහොමද දෙන්නේ කියලා examination එකේ clinically examine කරලා නේද? But yes, always think about thyroid cancer. මේ ලෙඩා hyperthyroid න තනි ගෙඩියක් තියෙනවා ලෙඩා hyperthyroid.
The toxic nodule.
Okay, now we no longer call it a toxic nodule, we call it AFTN. AFTN. AFTN stands for autonomously functioning thyroid nodule. Autonomously functioning thyroid nodule. It is the same thing as a STN, solitary toxic nodule, which was the nomenclature before. පරණ නාමකරණය. දැන් ඒකට කියන්නේ AFTN කියලා. හරි? There is no difference in the pathological processes, but that's a better name because it functions on its own. ඒ කතාව කියන්න එක වැදගත්. Okay. That is solitary nodule. Okay. Then what about you have nodules everywhere? You can very jolly well see one here, and one here. What are the diagnosis? Just a multinodular goiter, right? I mean, හරි. ඒ multinodular goiter එකත් එක්ක patient toxic න? hyperthyroid න? මොකද්ද කියන්නේ? දැන් තනියෙන් ගෙඩියක් තිබ්බා, patient is hyperthyroid, you said autonomously functioning thyroid nodule or else a toxic nodule. So there's a multinodular goiter and the patient is toxic.
The plumbers.
Toxic
Yeah,
multinodular.
plumbers, yes. But nowadays we don't go with the names. I mean, කෙනාගේ මේ නමෙන් හඳුන්වන්න අපි එච්චර කැමති නැහැ මේ වෙද්දි. මොකද ඒක තේරුමක් නැති වැඩක් නේ. ඔය 1700 800 ගණන් වල කතාවක් නිසා සමහර ඒවා ඉතින් තාම එහෙම තියෙනවා. But then again, you can always call, as Hamid said, a toxic MNG, toxic multinodular goiter. Okay, so now you know, you ask the patient to swallow, make sure that it is a goiter. Okay, first part done. Second part, go behind, completely go behind, right? Don't stay halfway and try to examine like that, right? Always go behind and check stabilize one side, check the other side, stabilize that side, check this side, and get to know whether you are dealing with a solitary nodule, MNG, or a diffuse goiter. So that is your main goal. Okay. Right. Then the third part is thinking about cervical lymphadenopathy. So I would like to mention something to you. When you are going to check on any patient, the word anticipation is very important, right? එහෙම ඒ කියන්නේ anticipation කියන්නේ ඔයා ඒක මෙයාට මේක තිබිය හැකි කියන අදහසක් තියෙන්න ඕනේ මෙයාගේ history හරි නැත්තම් goit එකේ පෙනුම කියන්නකො මේ situation එකේදී goit එකේ පෙනුම. ඒ කියන්නේ ඒකයි මම මේ discuss කරේ මේ common goiter shapes එක්ක එන්න පුළුවන් ලෙඩ මොනවාද කියන්නේ, right? උදාහරණයක් වශයෙන් අපි කියමු දැන් ඔයා තනි ගෙඩියක් දැක්කොත් patient කෙට්ටු නම් ඔයා හිතනවා maybe toxic, right? So you are talking with a AFTN. හරි. එහෙම නැත්තම් අපි කියමු ලොකු ගෙඩියක් තියෙනවා, ගෙඩියේදී මෙහෙම ලොකුවට තියෙනවා. ඉතින් ඔයා දැනගන්න ඕනේ එහෙමනම් compression වගේ මොනවා හරි තියෙනවා ඇති නේද? එහෙම කියලා හිතෙන්න ඕනේ. So that is anticipation. If you don't have any anticipation, then you are, and if you think that okay, I will do the standard examination, and then the disease will dawn to me. ඒ කියන්නේ මම ස්ටෑන්ඩඩ් එක්සැමිනේෂන් එක කරන් යනකොට ඒ හම් වෙන රෝග ලක්ෂණ වලින් මට ලෙඩේ හමු වෙයි. එහෙම ඉතින් හමු වෙන්නේ නැහැ. එහෙම හරි අමාරුයි හමු කරගන්න, right? So it's very difficult. So you have to think. දැන් මෙතන ගෙඩියක් තියෙනවා. You should know probably you are dealing with a ganglion. when you go and examine, it may be a lipoma. Yes, agreed. But then මෙතන තියෙනවා so these classic areas that you should understand. ඒකයි අපි හිතාගත්තේ එක එක shapes වලට අනුකූලව තියෙන ලෙඩ තියෙනවා. එතකොට ඒ ලෙඩේ වෙන්න පුළුවන් කියලා හිතාගෙන තමයි ඊටු examination එකට යන්න ඕනේ. So it's easier. It becomes easier then. Okay. So then the main thing is cervical lymphadenopathy. Okay. So can anybody tell me how many levels of cervical lymph nodes in the neck? Levels, how many levels? Okay. Like a silence, the silence means to me that most of you may not know about the cervical lymph node levels. So this is very, very important. A lot of MCQs have also been made now for like 3-4 years regarding levels of lymph nodes, right? I mean, I have seen we have made certain MCQs. We have made essays, SCQs on this also. So it is important for you to know the levels of lymph nodes in the neck. Because the neck short case is not only goiter. You might get a patient with neck lymph nodes, right? So you have to understand, okay, what is the level? Then what is the possible drainage organ, primary organ? Where is that? Right? You can then thyroid. අපි කියමු දැන් මෙන්න මෙතන තියෙනවා lymph node එකක් මේ mandible එක යට කන යට lymph node එකක් තියෙනවා කියන්නේ. So I mean that may not at all be due to the thyroid gland. It may be due to some problem in the ear canal, maybe some problem in your wisdom tooth, something like that, right? So if you don't know, I really suggest to you, please get to know your levels, right? In the exam, we are not going to ask you what is the exact border of these levels. කොතනින් එහාද තියෙන්නේ. හිම අපිට අවශ්‍යතාවයක් නැහැ. Roughly ඔයගොල්ලෝ කිව්වම අපිට හොඳ නම ඇති. Right? That is more than enough. But we want to see that you have an understanding where level 1 is, where level 2 is. Right? The level 1 can submental, level 2 can submandibular, level 3 can anterior to cervical to mastoid, upper jugular. Level 4 is lower jugular, right? Level 5 is in the posterior triangle, like in 5A, 5B කියලා දෙකට බෙදෙනවා. Then the level 6 is just side of the thyroid gland, and level 7 is behind the manubrium sternae, and ඔයාගේ virtuous node කියන එක තමයි සාමාන්‍ය level 7 කියලා ගන්න. So roughly එහෙම දැනගන්න ඕනේ. So when you go to check for cervical lymphadenopathy, you should check it as such. Right? Then ඔයා running comment කියනවා නම් okay, no level 1 nodes, no level 2 nodes, level 3 is okay, level 4 is okay, something like that. Okay, level 5 is okay, the posterior triangle. And if you it's very difficult for us not to give you like 70 marks, 65, 70. Upper, second upper එකක් වගේ අඩුම. Right? එහෙම කියන්න පුළුවන් හොඳයි මම කියනවා. So you start doing that, then you can get a very good mark. හරි. So cervical lymphadenopathy check කරන්නේ ඉස්සරහින්ද පස්සෙන්ද? patient ගේ ඔයා ඉන්නෝනේ ඉස්සරහින්ද පස්සෙන්ද?
පස්සෙන්.
You have to be behind, right? Just like you were checking for the thyroid. So whenever you are checking the thyroid, finish the cervical lymph node checking up as well. And always check only one side first. Right. And check both sides also. Okay. So you find certain cervical lymph nodes, no worries. Just keep that in mind. Okay. So goiter or not, shape of the goiter, then cervical lymphadenopathy. Okay. Now you come to the front. Okay. Right. Now the next is to check for the tracheal position. Okay. Can anybody tell me, are we going to check the tracheal position at the just above the manubrium in the jugular notch, or are we starting from the thyroid notch of the thyroid cartilage here, from above or below?
Thyroid above, sir.
Above. So Dilki, why do you think that you have to start from the above rather than from below?
Because here we check that whether trachea is deviate due to thyroid gland. So it's no point of checking behind, because if it can come back to the lower margin at exact point.
Okay, I'll adjust that answer. So try to say try to answer in short sentences, Dilki. The longer you make the sentence, the higher chance you are going to say unnecessary things. Maybe not incorrect things, but unnecessary things. So that we may be prompted to ask you something from what you said. So it's like this, no? You have a isthmus, so you have a goiter. So isthmus may be large, so you may not be able to check your trachea here anyway. Okay, that is one thing. But the main thing is trachea is central at the larynx, right? It is sure central. So you come from above like this. You just press upon it and see. Say if you have a left-sided large goiter, you anticipate the trachea shifting to the right. If you have a larger lump on this side, you anticipate the trachea shifting to the left. So anticipation. Then you check from the thyroid cartilage, thyroid notch, where everything is central. Then you slowly go downwards. So apart from checking the trachea in the situation of a tension pneumothorax, I think it is always better you start checking. If you are to check for trachea, start it from there. Right? As doctors, what we should do is go from what we know to what we don't know. දන්නා දේෙන් තමයි නොදන්නා දේට යන්න ඕන. නොදන්නා දේට ඉඳන් දන්නා දේට එන්න අවස්ථාවක් නැහැ. Okay. Okay. So trachea එක left the right the central the කියලා කියන්න ඕන. Okay. Then we come to retrosternal extension. Right. Can we check, can we say that there is or there is no retrosternal extension by just looking at the patient?
Yes, sir.
Vinura, what do you think?
Yeah, retrosternal extension patient must be dyspneic in the.
So Vinura, just practical sense එකෙන් හිතන්නකෝ, do you think we will give a dyspneic patient to your exam?
No.
No, obviously not. නේ. මෙහෙම හති දාන patient කෙනෙක් නැත්තම් ස්ට්‍රයිඩ් එකක් තියෙන කෙනෙක් එහෙම කෙනෙක් අපි exam දෙන්නේ නැහැ නේ, obviously. නේ. මෙතන සරව ගෙඩියක් තියෙනවා, මේ ඔන්න පිපුරුවා, මෙන්න පිපුරුවා. There's an abscess which is going to be ruptured and there's an ulcer which is bleeding. ඒ වගේ දේවල් අපි exam එකේ දෙන්නේ නැහැ නේ. So Vinura, what you say may not be the one which we are looking for. Anything else, Vinura, you can think of?
Sir, distended neck veins.
Dimitri, distended neck veins. මොනවාද distended neck vein එක ඔය කියන්නේ?
Internal jugular veins.
කොහොමද internal jugular එක පේන්නේ?
External jugular.
External jugular vein, right? So see, you can make mistakes. ඒ කියන්නේ දැන් අපි මේ අත පෙන්නලා මේකට plaster එකක් දාලා දෙනවා අහනවා. Okay, this is just a passing question. What are the bones which are fractured? පැනපු ගමන් කියනවා tibia fibula එක. ඒ වගේ තමයි. Tension එකට කියන දේවල්, right? So you may see the external jugulars distended, sorry, right? Okay. ඊටත් වැඩිය, when you ask the patient to swallow at the beginning, you may see the lower border nicely going up and down. You may see the lower border nicely going up and down, right? So that may be an early sign for you to say, okay, probably there is no retrosternal extension. So at your level, that is enough. But in truth, sometimes you may see the anterior border of the goiter, but posteriorly a small tongue-like structure may go down, right? And so that is okay. That is only a CT will show. But for the time being, remember to check the retrosternal goiter when you are looking at the lump going up and down, right? So how to properly check the retrosternal extension? ඔන්න දැන් ලොකු ගෙඩියක් මෙහෙම තියෙනවා, clavicle එක ගාවටම ඇවිල්ලා jugular notch එකක් පිරিলা තියෙන්නේ. So you anticipate retrosternal extension. How to check?
By percussion.
Okay, මම මේක කියලා දෙන්නම්. ඒක එක සැරේ කියලා දුන්නොත් ලේසි, right? So it's very easy. Remember, you percuss only on lung. You never percuss on bone, ribs, sternum or manubrium or the clavicle. Very simple. So what you do is, now you have demonstrated this. Okay, now you are going to the jugular notch. Okay, all of you can palpate your jugular notch now. Come palpate the jugular notch. Okay, now you are palpating jugular notch. You are now running your finger slowly down. Slowly down. You will see a small hump. What is kanda? Small hump. So that is the, can anybody say what that is?
Angle of Louis.
Correct. That is the
Angle.
external angle of Louis. It's not Louis, it's Louis. L-O-U-I-S. Yes, S is silent. Right. So that's where the second rib is. So you go lateral. So that is the second rib. Below that is the second intercostal space. So you put your finger, percuss it. Then go up, second rib, do nothing. First rib, first intercostal space. Then you have the clavicle and the first rib, do nothing. So at one side, only the second intercostal space and the first intercostal space you percuss to see. So the way I did it is completely wrong because I was percussing on my cloth, on my t-shirt. That is wrong. You cannot. So that is why you have to do a bit of exposure at that moment. Right? Hama uda tamai percuss karanna one. Bones uda percuss karanne naha. Very simple. So you listen to a resonant sound. You should have a resonant sound. If you have any dullness, you can suggest, I hear dullness, probably there is some rectosternal extension. So you may have to answer as, we may have to do a CT rather than only ultrasound. Right. So what about that famous sign? What is that famous sign for rectosternal extension?
Pemberton sign.
Pemberton sign. So if you want to do Pemberton sign, you should do it like this, not like that, right? Not like that, but like this. Because when you do that, there is less pressure on the superior mediastinum. But when you do this, there is a lot of pressure on the superior mediastinum. So this problem of compression of superior vena cava at the superior mediastinum is what we want to elicit. So this is not, I mean, this may be helpful in your MCQs also. Pemberton sign is not a specific sign for a retrosternal goiter who is compressing the SVC. Pemberton sign is a sign where you have a disorder called superior vena cava syndrome, which is where something in the superior mediastinum is compressing on the superior vena cava so that drainage from the head and neck is obstructed. Now they have to find out some other methods for the drainage. So one sign will be the distended external jugulars and facial veins. When you do that, you further compress the superior mediastinum and you augment. Where may rogalakshana tava වැඩි කරලා පෙන්නනවා. So that then and there you may see puffiness, facial swelling, sort of distended veins, and sometimes redness over the cheeks. But remember, this is better shown in a Caucasian person or a fair person, right? So most of us Sri Lankans will not demonstrate this, even though it is there, especially the color change. So please don't. I have seen candidates coming and then even just at the inspection, just doing the Pemberton sign. So please don't do that. Pemberton sign should only be elicited if you are having any dullness on your percussion. Otherwise, don't go there. Right. So then comes to the most important thing, thyroid status. So I think you know that you can ask couple of questions, important questions from the patients during your surgical short case. In your medicine and pediatric short cases, you can't ask anything apart from whether it's painful or not. But in surgery short cases, you can ask related questions because we need to know, say, inguinal hernia. We need to know whether the patient is having any risk factors, like whether she's a manual laborer who has to daily wage fellow, like the dawase padi hadek deya barusana kenekda, so that he may go back to work very quickly and come back in 3 months with the recurrence of the hernia. So as such, in this situation, we have to ask certain questions. Some of them are to understand what's the thyroid status. Some of them to understand whether you have any compression on the trachea or the esophagus. And one more question to ask, whether you have any problem with the recurrent laryngeal nerves. Right? මෙන්න මේ ප්‍රශ්න ටික තමයි අහන්න තියෙන්නේ. එතකොට, so when to ask these questions? Most of the candidates stop examination and ask questions. But then your 3 minutes are going on. Right? So please, in the short case, do not stop your examination to ask questions. Always, now you think in your mind, okay, these are the questions I should be asking in a goiter case. These are the questions I should be asking in an inguinal hernia short case. So where to ask them? So in the goiter short case, you should ask the questions while you are examining the thyroid gland, while you are examining the cervical lymphadenopathy, right? So that is the time to ask the question. So if you are hell-bent on doing, what do you call it, running commentary. ඒක සිංහලෙන් කිව්වොත් එහෙම කියන්නේ ඔයා ඉතා ආසාවෙන් කැමැත්තෙන් උත්සාහ කරන running commentary දෙන්න, and you will have to stop your chat and ask those questions, because otherwise at the back end, if you are stopping the examination and waiting to ask the questions, it looks like a observed history taking place, right? ඉතින් එහෙම අහන්න බෑ. So the point where you can ask these questions is ideally where you, when you examine the thyroid, when you examine for cervical lymphadenopathy. ඊට පස්සේ අහන්න පුළුවන්, but I am giving you a model where we have thoroughly polished this, set of examination skills, so that minimum time is wasted, so that you may be able to do this rather long short case during 3 minutes and have maybe 1.5 2 minutes for discussion, which is very important. That is the place where you become a classy fellow rather than an average fellow. Discussion එකෙන් තමයි class එකට ගොඩක් වෙලාවට ඔයාට, මොකද හැමෝම ඇවිල්ලා examine කරනවානේ. But the differentiation occurs at the discussion. ඉතින් ඔයා මේක දිගේම එල්බගෙන examine කර ගියොත් එහෙම එතකොට ඔයාට ඒ distinction එක ගන්න බැරුව යනවා. Anyway, right. Okay. So how to ask compression? කවුරු අහන්න මගෙන් trachea compression තියනවාද කියලා අහන්න කොහොමද? How to ask if I have tracheal compression?
හාන්සි වෙනකොට උස්ම ගන්න අවස්ථාවක් තියෙනවද?
So that is, you are asking about orthopnea, which usually will occur early. Yes. Or else you can ask if there is a large right-sided goiter, say you can adjust to a question. හාන්සි වෙනකොට කියන එක මේ වම් පැත්තේ ඇලේට නිදා ගන්නකොට හුස්ම ගන්න අමාරුද? Because now the trachea is compressed by the large goiter on the right side, right? එහෙම අහන්න පුළුවන්, but your question is all right. So anybody can ask whether the patient is having any dysphagia. කොහොමද ඒක අහන්නේ? Esophagus compression. Come on, when you have a long case in dysphagia.
කෑම ගිලින්න අමාරුවක් තියෙනවද?
කෑම ගිලින්න අමාරු. So see now, okay, good that Hamid asked that question so that I can teach you this, right? So your questions in your short cases should be foolproof. ඒ කියන්නේ foolproof කියන්නේ ඒ ප්‍රශ්නෙන් patient ඔව් නෑ වගේ උත්තරයක් දෙන්න තමයි පුළුවන් වෙන්න ඕනේ. ඒ ප්‍රශ්නේ ඔයා හදා ගන්න ඕනේ as such, so that the patient will not go sideways answering, setting up so many other questions for you to ask. එහෙම නැත්නම් full confusion එකක් එනවා. ඉතින් මම නම් සාමාන්‍යයෙන් අහන්නේ වර ළඟක ඉඳන් ගණාරයම ගිලිති පොඩ්ඩක් හිර වෙලා යනවා වගේ තේරෙනවාද කියලා. Because I don't want, I mean, this is not the position to elicit progressive dysphagia, right? කෑම කන්න අමාරුද කියලා ඇහුවොත් එහෙම it may be due to maybe aphthous ulcers, කටේ තුවාල තියෙනවා නම් තොලේ, maybe due to lack of teeth, right? තේරෙනවද මම කියන්නේ? එහෙම නැත්නම් කන්න ආස දෙය හම්බෙන්නේ නැහැ, කන්න වෙලාවක් හම්බෙන්නේ නැහැ, so many things, right? Okay. How to ask about recurrent laryngeal nerve problem?
ළඟින් කටහඬ වෙනසක් වෙලා තියෙනවද?
ඔව් ඒක ඉතින් අහන්න පුළුවන්. කටහඬ ඔයාගේ ළඟකදී දැන් ඔයාගේ කටහඬේ වෙනසක් තියෙනවා කියලා කට්ටිය කියනවාද කියලා. Because sometimes you may not understand that these subtle changes. Only a person who is calling you after some time may understand. Hamid, මොකද, what is your voice like? Why is your voice like this? It was different before. Oh my God, I couldn't even understand you. So that is the practical thing. ඉතින් ඒකෙන්ද ළඟකදී ඔයාගේ කටහඬ වෙනස් කියලා අනිත් අය කියනවා වගේ ඇහුවොත්, that's a very good question to ask even at a short case examination. Okay. Now there are hyperthyroid situations and hypothyroid situations, right? Please, whenever you are using the word hyper or hypo, show us a gesture also. We are talking about hypernatremia or we are talking about hypokalemia, right? Because most of the times in anxiety you are not pronunciating it properly. Hyper the hypo the කියලා අපිට ඇහෙන්නේ නැහැ හරියට. එහෙම ඇහුන්නේ නැත්නම් these are 50-50 answers. හරි අපේ මූණ දැක්ක ගමන් ඔයාලට තේරෙනවා අන්න වැරදි උත්තරයක් දුන්නා වගේ කියලා ඔයාලට අග්ගල ආන්සර් එක මාරු කරන්න පුළුවන්. But whereas the first answer might have been correct. Only that we didn't hear it very well because you didn't say it correctly, right? තේරෙනවද? එතකොට you might get all lost. Hence, I always talk about hyperthyroidism and hypothyroidism. Just have some gesture. Okay. Apart from Hamid, then වෙන කෙනෙක් කියන්න ඕන දැන් 4-5 දෙනෙක් හින්දා තමයි මේ discussion එක සම්පූර්ණ යන්නේ. හරි. කියන්න බලන්න තුනක් අහනවා නම් question තුනක් අහනවා නම් hyperthyroidism ගැන. Hyper
ළඟදී බර අඩු වෙලා තියෙනවද කෑවත්?
අන්න හරි. ඔයා සාමාන්‍ය විදිහට කෑවත් බර අඩු වෙනවද? එකයි. Okay. Anything else? මොකද ඇඩ් කරන්න ඇති ඉන්නවනේ. Yeah.
බඩ
net කියන්නේ.
බඩ බුරුලට යනවද?
ළඟකදී you use this as ළඟකදී ඉඳන් recent past. Otherwise some people might by practice they might go to the washroom to poop for 3 times a day. So we may ask ළඟකදී ඉඳන් බඩ බුරුල් කරලා යනවද? මල පහ දීර වගේ යනවද? Something like that. Okay. One more question.
ළඟදී මේ දාඩි දානවද වැඩියෙන්?
Right. So Netma, very good that you mentioned it. So usually it is better as we are living in a tropical country. අපි මේ සමකාසන්න රටක් නිසා we are near the equator. Please let's not ask about temperature questions, right? ඒක හරි අමාරුයි කියන්න උත්තර දෙන්න. But more than that you can ask about palpitations. Okay? මේ ඔයාට විටින් විට පපුව නිකන් ඩික් ගහලා ගහනවා වගේ නිකන් තේරෙනවද? හරි? ඒ වගේ දෙයක් ඇහුවනම් it's good. So maybe better to ask about palpitations, about diarrhea, about unintentional weight loss. Right? Unintentional weight loss. Okay. Hypothyroidism. Come on. Ask.
ළඟදී බර වැඩි වෙලා තියෙනවද?
බෑනේ. එහෙම බෑනේ අහන්න. එහෙම අහන්න බෑ. එතකොට ඒක fool proof නෑ.
වෙනදට වඩා කම්මැලි ගතියක් දැනෙනවද?
අපච්චි. කොහොමද කම්මැලිකම measure කරන්නේ? නේ සයිඩ්. එහෙම you can't measure laziness.
ළඟකදී නම් මල පහ යනකොට බඩ වේලවල යනවද?
Okay. Constipation. Recent onset constipation. Agreed. 1. අපි බර ගැන අහමු ඒක කොහොමද අහන්නේ ඒක? නෙත්ම හිතලා කියන්න බලන්න දැන් ඔයා කිව්වනේ ඉස්සලා කෑවත් බර බහිනවා කියලා කිව්වනේ.
සාමාන්‍ය මේ කෑමත් එක්ක බර වැඩි වෙනවද?
කෑම පාලනය කරත් බර වැඩි වෙනවද? Even though you are not eating that much, whether you are gaining weight. So that is you looks like pathological, right? So මේ කෑම ඔයා පාලනය කරත් බර වැඩි වෙනවා වගේ තියෙනවද? ළඟකදී දැන් ටිකක් මල පහ ඝනකමට යනවා වගේ තේරෙනවද? Sayumi, what were you telling?
lethargy,
Yeah. So let's not talk about lethargy. Let's talk about daytime somnolence. දවල් වරුවේ නිින්ද යාම. ඒක ගැන අහන්න. Sayumi, how to ask that?
දවල් කාලයට නිදිමත එනවද?
එහෙම සයමි අහපු ගමන් checkmate. මොකද දන්නවද? So a mother who is caring for a crying baby at night will be sleepy during the day. A man who is doing on call, maybe he's a security guard or maybe like you, one day a doctor who is on call may feel sleepy during the day. A mother who is waking up at 3 a.m. because the child is going to a school in Colombo may feel sleepy during the day. එතකොට ඒ questions එකක්වත් foolproof නෑ. So the question you should be asking is රැට හොඳට නිදාගත්තත් දවල්ට නිදිමතයි. Right? So these are the questions. හරිනේ? හරි. Okay. So this is basically the thing. Now you know, okay, we are dealing with a goiter of this shape and the patient has or has no cervical lymph nodes enlarged. Trachea is central or not. There is retrosternal extension or not. The patient is either hyperthyroid, euthyroid, or hypothyroid. So, and the patient does or does not have any compression symptoms, may or may not have a voice change. So now this is a rock solid short case now. It's very difficult if you touch upon all these. We definitely have to give you maybe 65 already. Now, if you go to discussion with this, it's just plus points. Okay. Then ideal situation එකේ ඔයා ඔය ටික කිව්වට පස්සේ then you have to yourself say, okay, how am I going to investigate this patient? ඒකත් කියලම තමයි ඔයා ඉවර කරලා අපිට බාර දෙන්න ඕනේ ඔන්න මගෙන් ප්‍රශ්න අහන්න කියලා. එහෙම කියන්න පුළුවන් නම් short case එක ලස්සනයි, හරිම straight forward. Say you do it, you demonstrate it to the examiners, you say what you have to say, you say what you think this patient has, and you say what you are going to do to prove it. Okay. So what are the investigations you want to do in this situation?
I would like to identify the thyroid status of this patient with the TSH and the TSH at least.
Oh, then ඇයි එහෙම කියන්නේ? ප්‍රශ්න දෙකක් තිබ්බ ඔයාගේ උත්තරේ. First is you said I would like to. It's like, now these are very professional discussions. I mean, we say Hamid, I would like to eat an ice cream, correct? So in a professional discussion, we don't use these words. We say I will do. It's always I. We කියලා එකක් නැහැ. Most of the times you say we can do. Yes, we can do so many things, right? We can go to a park, we can go to a movie, but in the exam situation, your answering should be, again foolproof. You should say I will do what I am going to do. So you say I will do a TSH. When you add the word at least, එතකොට ඔයාම ඔයාව doubt කරනවා. You are doubting your answer, right? ඒකම කියන්නේ you give short answers. To give short answers, you should think couple of seconds before answering, because otherwise when you are giving the answer, in the midway of answer, you will understand, oh shit, I'm telling nonsense. Okay. All right. So first of all, you say, I will do a biochemical examination by doing a third generation TSH and a free T4. That's the exact complete answer you can give to the situation. If the patient is obviously hyperthyroid, you can say I will do TSH third generation, free T4 and free T3. All right. Followed up by imaging. What's the imaging you want to do here?
An ultrasound neck to identify
An ultrasound scan of the neck. Okay. If you have any possibility of retrosternal extension, you would say I will also do a requester.
CT scan.
Incomplete answers, I mean.
NCCT neck.
What scan? What CT? You do a contrast enhanced CT of the neck and upper thorax. That is because sometimes the retrosternal component goes right up to the heart, aortic arch level. So that you have to do at least half of the thorax. So you usually say ECT neck and upper thorax. It doesn't matter. I mean, you can ask neck and thorax. That's all right. But CECT, contrast enhanced. It is not just a CT. If you say just a CT, we don't know whether you are talking about a contrast enhanced CT or a non-contrast CT. Non-contrast CT has no place in this situation. All right. So something I didn't share with you about the Graves. Okay, so I will tell it quickly because time is going on and you must be all tired now listening to me harping on. So Graves disease, then don't come and try to check eye signs in each and every patient. Right? That's a common mistake you do. Please don't check. If you have a diffuse goiter, by the looks of the patient is thin built and eyes are a bit popping out, okay, this can be Graves, no worries. Then you check. if the patient is hyperthyroid, right? It's highly unlikely that you are having this without any features of hyperthyroidism, right? Okay, so what are the eye signs you want to check? Can anybody tell? Eye signs, graves,
Exophthalmos,
exophthalmos,
proptosis,
proptosis,
chemosis,
chemosis, my God.
ophthalmoplegia,
Okay.
lid retardation,
Oh my God, there is nothing like that. Retardation can retard වෙනවා කියන්නේ ආබාධිත වෙනවා කියන එක නේ. There is no ආබාධිත වීම in the lid. You are trying to say lid retraction. Lid retraction and
lid lag.
lid lag. All right. So I'll quickly show you how you are going to check it, right? So, okay. I get my eye close to you. So to check eye signs, you have to be at the same level of the patient's eyes. So you may have to get down, right? Okay. So lid lag is when you are having the white of the eye shown above the superior limbus, right? And the eyelid, you should see the white of the eye. That is lid retraction. Exophthalmos is you should see the white of the eye in between the inferior limbus and the lower eyelid. So you should see some. So when both are there, people usually call it proptosis, right? So exophthalmos, white of the eye, downstairs. Lid retraction, white of the eye, upstairs. Okay. So how to check for proptosis, that eye is really popping out, right? So generally people would come while they are behind, they would come from the top of the head and just peep like that. මෙන්න මෙහෙම නැමිලා බලනවා ඇස් දෙක මෙහෙම එළියට ඇවිල්ලාද කියලා. But that is very unprofessional. Say there's a woman with a low cut dress and you coming from behind and try to peep like that, you may see the woman's cleavage and the patient will be really uncomfortable at that situation. So nowadays we never peep. හොරෙන් බලන්නේ නැත, right? So you go, say this my hand is the patient. So you go from sideways and check whether you have any proptosis, right? Sideways, always sideways. Never peep like that. Okay. So exophthalmos, lid retraction, proptosis. Then comes lid lag, right? So lid lag, it's like this. You keep one of your hands on the patient's head and stabilize it. කියනවා ඔළුව උස්සන්න එපා. මේ ඇඟිල්ල දිහා බලන් ඉන්න, right? Okay, then you take it right up. Now you are looking at it right up. දැන් මම මේක පල්ලෙහා ගෙනවා, මේක දිහා බලන් ඉන්න. Now I'm going to take it down. Look at this, huh? Right? Once or twice. So what you are trying to look at is whether the eyeball is faster than the upper eyelid. So ideally this is the eyeball, this is the upper eyelid. The eyeball should come like that and the eyelid also at the same speed. But when you have lid lag, eyeball comes down, this is lagging behind, right? So you are seeing white of the eye all the time. All right. So that is lid lag. Chemosis is just you see the eye is injected, that is eye is red, this chemosis. And ophthalmoplegia, if you have time, of course, you can just stop it here and do an H. You know this, right? Do an H and see how it goes. So all these should be done if you are thinking the patient is having Graves' disease, right? So don't try to do this on every patient. I have seen some people doing an inspection. So it's just a waste of time, right? Most of the patients are not like that. All right. So this is eye examination when needed, right? Then there are a couple of things you should know about a hyperthyroid patient. If the patient is obviously hyperthyroid from your questions, then you can do a couple of things in the upper limb, right? So I'm going to quickly show you this. This can be done within about 30 seconds. Okay. So first, palmar sweating. මේ අතනේ අපේ මේ මගේ අත examiner ගේ අත. This is the patient's hand, right? So palmar sweating. ඔහොම කරපු ගමන් whether it's sweaty, right? Then turn it, go and have a look about like something like clubbing, thyroid acropathy. Some people call it acropathy, right? Whatever, no, never mind. Second, two things: thyroid acropathy, palmar sweating. Then you ask the patient to extend the hands and extend all the fingers. Now you can see just a bit of tremors are there. I think you should carry a small piece of paper, maybe a small cardboard. I used to carry that because if the tremor is not very obvious, you can just put that piece of cardboard like that. Now the tremor will be more obvious, right? Why I asked to put a cardboard and not a piece of paper? Always there are fans going on when you are doing the exam, and if you put a small piece of paper, that will just fly away, and you will be running behind it and waste important seconds. So, palmar sweating, thyroid acropathy, fine tremors, pulse, rapid tachycardia, and irregular rhythm may be also there, right? So 4 things now. Palmar sweating, thyroid acropathy, tremors, pulse. And then if you have time, you can just check the biceps reflex also, which will be brisk. And in hyperthyroidism, you may have difficulty in lacking of power in the proximal musculature. So I usually ask them to do this. So, scratch the back, right? So that is to say proximal myopathy is there or not. So at least try to do in a hyperthyroid patient the fine tremors and the pulse. At least those 2 things, right? So that is only if you are thinking the patient is hyperthyroid. Eye signs only if you are thinking you are dealing with something like Graves, right? Diffuse goiter, hyperthyroid. Some eye signs are possible. Eye looks a bit big. Then okay. Then no worries. You go ahead. No worries. Hurry. Okay. So now we have discussed a lot about thyroid examination, right? I'll just summarize again. Consent, privacy, chaperone, lighting, exposure, positioning. Then you go for understand whether this lump is a goiter or not. Okay, if it is a goiter, what is the shape of it? Then you go for cervical lymphadenopathy. Then you go for tracheal placement. Then you go for retrosternal extension. But please, if you can see the goiter nicely moving up and down the lower border, please don't do retrosternal extension examination. There is no point. You can always say, I can see the lower borders very well. It is moving nicely up and down. Doesn't seem to have any retrosternal extension, right? Then finally, the questions, the thyroid status, compression of the trachea or esophagus, and voice change. See, the compression questions you should ask maybe only when the patient has a large goiter, large multinodular goiter like that. Very small goiter, even though you don't ask these questions of compression, we don't mind. But large goiter, yes. Okay, then the examiner might ask you, okay, what are the instances where you are going to do a thyroidectomy? Traditionally 5 C's කියලා තියෙනවා. C 5ක් මොනවාද?
Cosmosis.
Cosmesis is Dilki. You have the tendency to say the least common answer first. So always think common things occur commonly, rare things occur rarely. So in that sense, cosmesis is the least of the reasons. First is?
Carcinoma.
Okay. Compression, cancer. Those are the 2 common things. Okay. Dekai. Cosmesis, pahai. Tahu deka?
Children.
Huh? Can't hear.
Children, sir.
Children? Dimitri, I can't hear you.
In children, sir.
No. It is children, it can be a physiological goiter. No? Okay, I'll tell you. Compression, cancer, control. Control is hyperthyroidism. We never do operations for hypothyroidism because you can always use thyroxine, right? We don't want to. But hyperthyroidism, we may not be able to control by drugs, especially if you are dealing with a toxic multinodular goiter. We give carbimazole-like drugs only to control so that we can do the surgery. These are never lifelong drugs. Carbimazole or other antithyroid drugs are never lifelong drugs. They are just to control up to the surgery. But in Graves' disease, as it is an autoimmune disorder, sometimes if you control the thyrotoxicosis for a time being, it may go down on its own, means remit on its own. But of course, it can relapse. Right? So if it keeps on relapsing, we might have to take the thyroid out. Right? Otherwise, toxic malnutrition goiter, solitary thyroid nodule, toxic nodule, which you call AFTN, definitely has to come out only after control by the carbimazole. The other one is come again. Come again is recurrent goiter. Recurrent goiter you may have to do. And as Dimitri said, in children, if you talk about children's goiters, most of the times we may have to do unless it is physiological, because they tend to have cancers more, and these cancers are fairly aggressive than an adult person getting the same pathological type of cancer. Then, of course, somebody mentioned cosmesis. Yes, but in the government sector, it is very difficult for us to find time for cosmetic reasons. And then there are, when there is retrosternal extension, definitely we have to think about doing it early, because if you allow it to sit for like 4 or 5 years, it may go beyond, and we may have to cut open the manubrium or the sternum to get it out. So that is the thoracotomy or a manubriotomy. So that is going to be a real complex surgery. So in that sense, if you feel any retrosternal extension is there clinically and confirmed by radiology later on, best to go ahead. But that is not coming under the 5 C's. So that's what I'm telling you. 5 C's are the common ones. There are some other indications as well. Okay. So say now you do ultrasound examination and there is a nodule which is suspicious. How can you say a nodule is suspicious on ultrasound? What is the method?
So there are suspicious features of the nodule, such as microcalcifications, if there's increased nodular vascularity.
So, Hamid, now you are not answering my question. You are explaining the answer. The answer which I am looking for is a thing called classification called Thyroid's classification. You know this, right? Hamid, you know this?
Yes, sir.
Yeah. So when answering, you say the Thyroid's classification first and then describe, okay, there can be microcalcifications, there can be regular borders, hypoechoic lesion, solid lesion. Right? Now, if you can describe like that, you are like plus 70. Right? So game over for others, right? But we don't expect that much. But if you can say, like in BIRATS, there is TIRADS. Breast cancer, there is BIRATS. In suspicious thyroid nodules, we have the TIRADS classification. Hi? Okay. So, okay, there's a TIRADS suspicious nodule is there. We don't want you to know TIRADS numbers 3, 4, 5. Okay. Now, how do you proceed from here? There's a suspicious nodule.
To histology.
Vinura, what is histology to you? How can you get histology? Histology වෙන්න නම් අපි pathologist මොකක්ද යවන්න sample එක? Vinura.
Fine needle aspirations.
ඒකට මොකක්ද කියන්නේ කෙටි යෙදුම?
FNAC.
FNAC නේ. What does C stand for?
Cytology.
Cytology. So is cytology histology?
No, sir.
No. So you have given a wrong answer, right? So don't mix up these basic stuff. So what you do is a fine needle aspiration for cytology. That's why we have to always say the proper term. ඒ කියන්නේ FNAC වගේ කියන්නේ නැතුව we say fine needle aspiration of cytology because that answer itself explains. So if you want histology, you need to send to the pathologist at least a core biopsy sample, which usually is the sample which is taken from a breast lump. අපි සාමාන්‍ය breast lump එකේ FNAC දැන් කරන්නේ නැහැ. මොකද අපිට ඒක කරලා වැඩක් නැහැ. breast cancer එක නම් අපි worry එක තියෙන්නේ. We need to have histology because we need to have the breast cancer receptors, the PR, මොනවාද? ER, PR and HER2 receptors. දැන් අපිට goit එකේ අපිට බෑ මේ core biopsy කියන එක වැඩි recommend කරන්න. Why? Any thoughts?
It can bleed heavily.
Vasculature is high, sir.
Okay, so now you have some ideas. So this is the correct answer for this. neck is a tight compartment which has a lot of important structures. In doing core biopsy, where there is a spring-loaded gun, you may damage esophagus, trachea, intrajugular vein, carotid artery, vagus nerve, recurrent laryngeal nerve, and the thyroid. Thyroid is also a very vascular organ. So you may have bleeding if you damage a vascular structure. You may have esophageal leak and so much of trouble if you damage the esophagus. You will have surgical emphysema if you damage the trachea. If you damage a nerve, you are done, right? And if there is bleeding into it, then the patient will very quickly develop stridor and may lose the life as well. But there are a lot of important vascular structures and other tubular structures which can get damaged by core biopsy. ඒ නිසා අපි core biopsy සාමාන්‍යයෙන් recommend කරන්නේ නැහැ. But somebody was talking about thyroid lymphoma earlier, and there is a thing called anaplastic carcinoma also. So ඔයාට දැනගන්න ඕන නම් මම කියන්නම්. Anaplastic carcinoma and thyroid lymphoma both clinically look the same, and by FNAC you cannot differentiate. Anaplastic carcinoma, you die whatever the surgeon does within 6 to 9 months, you are gone at the current rate. But thyroid lymphoma, even without surgery, if you diagnose, you can give radiotherapy and chemotherapy and maybe get a complete cure even without surgery. So අන්න ඒ දෙක වෙන් කරගන්න core biopsy කරනවා හොඳට හැකියාව තියෙන කෙනෙක්, radiologist, and with a short core biopsy needle. Breast cancer වලට කරන දිග core biopsy needle එක නෙමෙයි. There's a short core biopsy needle. මේක දැනුමට කිව්වේ කවුරුත් අයන් අහන එකක් නැහැ. Okay. So you send a cytology report. Okay. Cytology classification නෑ මොකද්ද?
Bethesda.
Bethesda classification තමයි අපි දැන් බලන්න කියන්නේ. ඒක 1 2 3 4 5 6 කියලා තියෙනවා. ඒක ටිකක් බලාගත්තට කමක් නැහැ, because we may ask some questions from that, and if it comes to that point, that means you have earned a lot of marks and you may be able to go for a medal or a distinction then මේ level එකේ යනකොට. හරි. ඉතින් the Bethesda සාමාන්‍යයෙන් 4 5 6 meaning we have to operate, right? ඉතින් මේක මම දැනට කියන්න නැහැ, ඒක long topic එකක්. චුට්ටක් බලාගත්තට කමක් නැහැ. වගුවක්, you have a look at a table what it says. So if there is any suspicion of cancer or proven cancer, we have to go forward. Hari. What are the three common cancers?
Follicular,
papillary, and medullary. So don't forget about medullary. It is not your business. Talk about follicular and papillary. Hari. ගෙඩියක් තියෙනවා එක පැත්තක, ඒක cancer කියලා ආවා. Total thyroid ද කරන්නේ, hemithyroid ද කරන්නේ?
hemithyroid.
මලා. ඒ hemithyroid කරන්නේ. So you have only 3 surgeries in the thyroid gland. One is total thyroidectomy. One is hemithyroidectomy. Hemithyroidectomy කියන්නේ thyroid lobe and the isthmus. There is nothing called lobectomy. එහෙම එකක් නැහැ. Then there's another surgery called completion thyroidectomy. Hemithyroidectomy කරපු කෙනාව ඉතුරු කැලලත් අයින් කරනවා, completion thyroidectomy. So baseline ඕගලන්ගේ මට්ටමේ තේරුම් ගන්න. If you are having a thyroid cancer, best is to do a total thyroidectomy, because these cancers are usually multifocal, right? That is one thing. And most of these cancers will need radioactive iodine therapy later. एक criteria ගොඩක් තියෙනවා. මම එකක් විතරක් කිව්වොත්, usually more than 1 centimeter diameter එකක් තියෙනවා නම් we are thinking of giving at least some amount of radioactive iodine. You cannot give radioactive, the purpose of radioactive iodine after a total thyroidectomy is to treat lymph node mets, small ones, and distal mets like lung and bone. So if you only remove half, if you have the other half here and you give radioactive iodine, all that radioactive iodine will be absorbed by the remaining thyroid gland. It will never go and kill any distal metastasis. So in that sense, one is thyroid cancers are usually multifocal, what we were talking about, can be multifocal. And secondarily, if you give radioactive iodine, you can't give having parts of thyroid remaining there. So that's why we usually go for total thyroidectomy and not hemithyroidectomy. Words like subtotal thyroidectomy or near total thyroidectomy are obsolete at this point. I think you know the word obsolete. යල් පැනපු කල් ඉක්ුතු වචන සහ procedures මේ කාලේ එහෙම කවුරුත් කරන්න යන්නේ නැහැ. හරි. Okay, I think, I mean, we touched upon almost all the things. If you have any questions, let's have a couple of minutes of questions.
Excuse me, sir. If it was a well-differentiated carcinoma, which is less than 1 centimeter and low risk, we still can't do a lobectomy?
So, Nitma, I just mentioned there is nothing called lobectomy. Right? What you are talking about, whether I can do a hemithyroidectomy. So, this is a complex scenario. You have to know, okay, so say there's a malignancy less than 1 centimeter that is called a micropapillary carcinoma if it is a papillary one. In follicular ones, we don't call it microfollicular, right? So if it is follicular, there is higher chance of vascular and lymphatic invasion, which we will only know when the histology report comes. In that sense, if you are dealing with a follicular cancer, and from cytology, you cannot differentiate follicular adenoma from follicular carcinoma also. Right? So if you are dealing with a follicular disease in cytology and the ultrasound is suspicious, I would usually go for a total if the lump is large. This is follicular, right? But commoner one is the papillary one. So your question was micropapillary cancer, whether we can do a hemithyroidectomy and wait. Yes, but then there are other things which should support you. There shouldn't be any suspicious lymph nodes. There shouldn't be any extra thyroidal extension, ETE we call it. ඒ කියන්නේ ළඟ තියෙන strap muscle වලට හරි. ඒ කියන්නේ හිතන්නකො මේ ටියුමර් එක තියෙනවා කියලා thyroid එකේ border එක. And then you very closely see whether this border is there any normal thyroid rim in between your lump and the border. එහෙම තිබ්බොත් හොඳයි. But if it is touching, if it is on the border, then probably you are having extra thyroid extension, which means you cannot just remove that and wait. You have to give radioactive iodine. Lymph node නැති වෙන්න ඕනේ. සෙන්ටිමීටර අඩු වෙන්න ඕනේ. එකක් පමණක් තියෙන්න ඕනේ. එක සස්පිෂන් කැන්සර් එකක් විතරක් තියෙන්න ඕනේ. එක්ස්ට්‍රා තයිරොයිඩ් එක්ස්ටෙන්ෂන් නැති වෙන්න ඕනේ. ඩිස්ටල් මෙටාස්ටේසිස් මොන හරි තියෙනවා වගේ රෝග ලක්ෂණයක් නැති වෙන්න ඕනේ. එහෙම ගොඩක් ඒවා තියෙනවා. හෙමිතයිරොයිඩෙක්ටමි විතරක් කරලා බලන්න. Especially I can go if it is the nodule is on the right side and there are so many nodules on the left side also. I think ඒකෙන් එකක හැංගිලා තියෙන්න පුළුවන් micro cancer එක. So it becomes now multifocal. Right? So it's very rarely you get to do this. But in other countries, say the person is 65 years of age and maybe the life expectancy is like less than 10 years. Right? Okay, no problem. You take it out, you observe. Annually or 6 monthly, you observe going on and on. But it's a complex situation and complex answer for probably for a trainee in surgery rather than for a MBBS student. Any other questions? Dimitri can't hear.
So in examination, auscultation is must?
No, auscultation is not a must at all. If you are having a hyperthyroid patient, that is the only point where you should go for auscultation by using the bell of your stethoscope, and you have to ask, and you have to keep it at the upper pole, right? Because that's where the superior thyroid artery and the most vasculature is. So you have to ask the patient to take a deep breath, hold it, then you put the bell and see. Otherwise, if the patient is still breathing, then that trachea, the air going through and fro from the trachea will also, you will feel it like a bruit. T is silent. Don't come and say there's a thyroid bruit. People come and say. That's the only situation where you might need the auscultation. Yeah.
Then must we need to look for carotid pulse deviation?
That is, if the goiter is really large, really large, you can check where the carotids are. That you can do, but but what you are talking about, I think mostly is the Berry sign. Which is called the Berry sign is that absence of carotid pulse. That happens when you have a large goiter with a large cancer encroaching circumferentially the carotid artery. then you cannot palpate the pulse. Right? These all happen in large goiters. බැලුවා කියලා කමක් නැහැ. නොබැලුවා කියලා අපි ලකුණු කපන්නේ නැහැ. කිසිසේත්ම, because that you have to definitely do a CT. If it's a very large goiter, you have to definitely do a CT because you don't know how it compresses the vasculature, whether it's attached to the vasculature. ඉතින් ඒ වගේ දේවල් ටිකක් සංකීර්ණ දේවල්. ඔයගොල්ලන් නොකියුවා කියලා ලකුණු කැපෙන්නේ නැත.
So for a follicular carcinoma, our hemithyroidectomy is followed by frozen section, then complete completion
So
hemithyroidectomy.
first of all, you don't know whether you are dealing with a follicular cancer or not. You can FNAC will only tell you follicular nodular disease, so follicular adenoma or carcinoma, right? So actually, people in other countries are trying to do core biopsy for this also, but it is very risky. So don't talk about that at the exam. So we don't know. So we are the minimum surgery is hemithyroidectomy. So your question, okay, are we going to do frozen section? Frozen section may not reveal much. So in that sense, we do not do frozen sections nowadays on table so as to diagnose and complete it. Right? ඒවල sensitivity specificity කියනවා very low. So that is why ඒක කරන්න බැරි කම නිසා නෙමෙයි. ඒවල sensitivity specificity very low. So you doing it and going ahead with the completion at the same time or not doing it, maybe doing too much or too little. ඒ නිසා අපි බලන්නේ okay. Please say if there are nodules on the other side, obviously better to go for a total thyroidectomy. But if it is a follicular lesion, yes, if the patient is also agrees, you do a hemithyroidectomy, see the histology. If it is cancer, go and do the completion. No worry. But only thing is, in the government sector, it is pretty difficult to find 2 days to operate the same person. Your practical level. Ideal situation is do hemi, see the histo, go and do completion if required.
Thank you, sir. So also, what's the point of the suppression dose of levothyroxine, sir? So what's the basis behind that?
Yes, very frequently asked question. Follicular cancer and papillary cancer. These two cancers, they grow with the effect of TSH, thyrotropin stimulating hormone. They grow. So say you remove the thyroid. So what happens to the maybe some micrometastasis everywhere in the body? So these will also grow if TSH is there. So because of that, we try to suppress the TSH after the surgery by giving a higher dose. So remember, if you do thyroidectomy for a benign goiter, or if somebody is having hypothyroidism, the daily dose is body weight multiplied by 1.6 benign. If somebody is having hypothyroidism or if somebody is having benign thyroid disease, 1.6 multiplied. So meaning if somebody is 50 kilos, it is roughly around 75 micrograms per day. But following surgery, if we are discussing about a cancer, then we have to multiply body weight by 2.1. So if somebody is 50, now it is about 100. So that's how we suppress the TSH. But the suppression is not lifelong. It is about for 3 to 5 years, maximally 5 years, minimally 3 years, right? Because you can't go on and give higher doses of thyroxine because the person may get cardiac problems and less bone density, resulting in pathological fractures in the long run. Yeah.
So then, if we're giving radioiodine for patients, sir, wouldn't radioiodine require TSH to be driven into the
Yeah, so when you are giving suppressive thyroxine dose, these are really beyond your scope, but as you have asked, I am telling. So usually when you are giving suppressive dose, you usually stop for 2 to 3 weeks before the radioactive iodine dosage, so that you allow TSH to become normal and you allow these micromets to become a bit, if they are there, to become a bit prominent, so that when radioactive iodine comes, it is easier to kill. Yes. We stopped the thyroxine about 2 to 3 weeks earlier, but in other countries where money is available in terms of insurance, they give a thing called recombinant TSH 72 hours before, so that you don't have to stop the thyroxine. Because when you stop thyroxine also for 2 to 3 weeks, you start feeling hypothyroid. That is very difficult. Right? ඒක block කරගන්න they give recombinant TSH 2 to 3 days before.
So then when do we check thyroglobulin levels after surgery?
Yes, first thing to know is serum thyroglobulin you never check before the surgery. You never check. It is not a tumor marker when the thyroid gland is there, or if, even though the part is there. එහෙම කවදාවත් කරන්න එපා serum thyroglobulin, absolutely no point. So I'll tell this once. Once you remove the thyroid gland, after about 2 months, you have to do serum thyroglobulin, right? Because thyroglobulin is made by normal thyroid tissue. It is made also by cancer thyroid tissue, right? So if serum thyroglobulin is high, that means two things. Either there is a cancer somewhere, or you have not removed the thyroid gland completely. Right? So that is one thing. The second test you do there is serum anti-thyroglobulin antibody. Serum anti-thyroglobulin antibody. Because some of these patients may have, say, things like Hashimoto's also. So these patients may have antibodies against thyroglobulin. So these are called anti-thyroglobulin antibody. So if they are hanging around, even though you have some thyroid left here or thyroid cancer anywhere else, the thyroglobulin level will be falsely low. Why? The anti-thyroglobulin antibody is not allowing the thyroglobulin to go up. So after your surgery, about 2 months after, when you think that all the whatever which was there made before has subsided, you do these two tests. If thyroglobulin is high and anti-thyroglobulin level is low, it means either something is left in the neck or something is in as metastasis, or both. If thyroglobulin is low and anti-thyroglobulin is high, that means meds or local stuff may be there or not. We don't know, because anti-thyroglobulin level is high. Agree? Okay. If serum thyroglobulin also low, anti-thyroglobulin also low, it is highly likely nothing is remaining in the neck. Probably nothing is in the as metastasis. Okay. So if anti-thyroglobulin level is low and thyroglobulin is high or something, we choose thyroglobulin as the tumor marker, biochemical tumor marker, to check for recurrence, biochemical recurrence afterwards, like for 3 to 5 years. If thyroglobulin is low and anti-thyroglobulin level is high, from that point onwards, we use the anti-thyroglobulin antibody as the tumor marker, not serum thyroglobulin. මොකද ඒක කොහොමද දැන් පාතයි අරක වැඩි නිසා. එතකොට අපි කියන anti-thyroglobulin එක වැඩි වෙනවායි කියන්නේ එහෙනම් ආයෙ අලුතෙන් ඇවිල්ලා දන්නේ නැහැ. මොකද එයා ප්‍රතිරුද්ධව තියෙන එකට තමයි වැඩිපුර වැඩ කරන්නේ. Agree? එතකොට ඒ biochemical recurrence, that is biochemical recurrence, and of course at 2 months you do ultrasound neck to see whether there are anything in the thyroid bed where we removed the thyroid gland and any lymph nodes. ඉතින් ඔන්න ඔය ටික කරලා you have to send to oncologist where they will set up for radioactive iodine, and the Maharagama fellows also will do a radioactive iodine scan, small scan, so it may show certain areas where metastases are there, and then they will give the radioactive iodine. Hari. Anything else?
So thyroglobulin should be undetectable or low? Because
Less
if
than
it's low,
0.2 nanograms per liter. See, now you have to understand. Then one might think, okay, thyroid gland is not there. If no cancer is there, then should be 0, right? But it is not like that, because most of the times, the tests do not only catch thyroglobulin. They sometimes catch some unknown material also as thyroglobulin. එහෙම එකක් තියෙනවා. ඒ නිසා ඒක 0 වෙන්නේ නැහැ. It's all right. එහෙම 0 වෙන්න අවස්ථාවක් නැහැ. like like sometime before අපි ඔය පැරාත් හෝමෝන් කියලා එකක් ටෙස්ට් කරනකොට ඒකත් එක්ක ඒකේ byproducts උත් එකතු වෙලා තමයි ගණන් කරන්නේ. එතකොට PTH high වගේ. But now we have refined that test so that only PTH will be checked. ඉස්සර එහෙම නෙමෙයි. ඉස්සර PTH check කරනකොට like 20 years ago when you check for PTH related protein කියලා තියෙනවා. ඒවත් check වෙනවා and byproducts check වෙනවා so that PTH is high anyway. වැරදි. ඒ වගේ තමයි හිතන්න එපා. බිඳු වෙන්න ඕන කියලා හිතන්න එපා. ඒක 0.2 nanogram sorry 2 nanograms per liter cut off with.
So someone asked in the chat, when do we start thyroxine after thyroidectomy?
Depends. Some of the surgeons say that they are of the practice to start thyroxine 3 to 4 days after even. So for that you have to understand what is the half-life of T4. Usually it is 4 to 5 days. So I mean you don't have to start the next day, but you can start a couple of days after also. But then again, we start usually the next day because then it is very easy for us to inform the patient and train the patient of how to take it properly. So there is no hard and fast rule. Best to start the next day.
Thank you, sir.
Any other questions? Sir, can we diagnose papillary cancer with FNAC and are we doing total therapy for that? Oh, yes. We can diagnose papillary. We do diagnose papillary CA from FNAC. Yes.
Thank you very much, Dr. Pinto. Actually, it is a very interesting, comprehensive, interactive session. I think that will be very helpful for our students who are waiting for your final MBBS exam. I think, Kalania, you start your exam tomorrow.
Yeah.
Then, actually, our aim was to expose you to expert on particular topics. Therefore, that during last sessions also we discussed a lot of cases with some expert in Sri Lanka. Therefore, I think that it will be very helpful for you. Then all the best for your final MBBS exam. And also I thank Dr. Pinto again. Thank you very much. We need your help in the future also.
No worries. You have helped me more than you know.
Okay, right.
Okay, take care. Good night all.
Good night.
Thank you, sir.
So one moment. Excuse me, sir. So on behalf of the entire student body, including the Faculty of Medicine, Wayaba University of Sri Lanka, we are quite thankful for today's session. Dr. Diluk from the Faculty of Medicine, University of Ragama, for today's session. And also, I believe I speak on behalf of thousands of students who joined the session over the last 8 days to cover almost all surgical cases, which will be quite invaluable to our future exams, which is coming up in a matter of weeks. So, sir, we are quite thankful especially for the department head, Dr. Gamini Abesingha, although he might not be here today, for organizing this session. And also, sir, Dr. Dixon Vikramratna, for finding out resource persons who are quite educated, and they were very helpful in all aspects regarding the exam and also different aspects of each surgical case. So, sir, thank you once again. And we hope that these sessions will be not just be important to us and also the future batches who are willing to access these as reference material in the future. So, sir, thank you once again and good night.